We're doing ECGs, ABGs and X-rays. My name's Eleanor. I didn't train here, I trained in Bristol, but I've met a couple of you and found out a bit about what your exams are like and what you're preparing for. I'm working in Bradford at the moment, and I started out in stroke. I'm now doing colorectal surgery, and I'm doing renal medicine to finish. So I'm going to take you through ECGs, and then hopefully Tej will be here, and we'll go through ABGs together, and then some X-rays. The aims are to pass the OSCE. So good luck everybody. When is the exam?
May and May 1st.
Okay, great. So you've got a little bit of time. So what I want you to be able to do by the end of this is to be able to interpret an ECG using a systematic approach. So it's nothing new, it's just going over it and getting really slick at it. And then be able to interpret ABGs and know what to do about them. And then recognise key findings on chest X-rays and just a couple of abdominal X-rays. And also, of course, the competent F1. How you're feeling about working next year?
Can't wait.
I'm not even going to ask you where you've been allocated because I know they've screwed that up. But anyway, so ECGs, systematic approach, and then we're going to have a few clinical scenarios, and I think we'll just go around kind of one by one, whoever wants to volunteer. This look familiar? Good. So how do you read an ECG? Well, first of all, if you break it down, step one, always going back to the basics: name, date of birth, date and time, and if they're in chest pain, if they have chest pain. They're really, really essential, especially if you've got a series of ECGs to look at together over time. You need to know exactly when each one's done. You need to know the rate, the rhythm, and the axis. So how do you calculate rate?
Number of big boxes between each complex into 300.
Yeah, you can use that method. Does anybody use a different method?
Count the QRSs and times by 6.
Brilliant. And that's if you've got a 10-second tracing. So good, so you can do that. So if I was to say that there were 4 small squares between each RR, how fast would that be going? Good. And then we look at rhythm. So what are the P waves doing? So are they there, first of all, and what's their relation to the QRS complex, and then axis? Does everyone feel happy with axis? Good. And so I always use lead 1 and 2, and I think that's what you've been taught to do as well, and then you just check that with lead 3 to make sure it all is in accordance. So whenever you're presenting, this is an ECG of Bob, taken on the 28th of February, and he has chest pain. The rate is 40 beats per minute. The rhythm is whatever, heart block, and he's got left axis deviation. The most obvious abnormality is whatever, anterior ST elevation. So just a few words on axis. You said that you're happy with it, which is great. I've got a little diagram in the corner if you were confused. So causes of left axis and right axis, I've just put them in the table, and ECG Made Easy is amazing for this. So causes of left axis deviation is either, when you see it, it is important to note, and it could indicate anterior fascicular block, so you've got a mild conduction abnormality. It could be a sign of left heart strain, in particular if you've got left ventricular hypertrophy and you've got left axis deviation, then it's a bad sign. And if you've got it in conjunction with right bundle branch block, then it's bad news because it means that you've got bifascicular block. And right axis deviation, so a few causes, so you can look slick. Right ventricular hypertrophy, posterior fascicular block, which apparently is very uncommon, and also a sign of right heart strain. So if you've got a massive PE, then you might see right axis deviation. It's not good news. But they can also be normal findings if you're tall and thin, and also ECG Made Easy says if you're short and fat, so it pretty much covers everybody. So these are just a couple of causes of axis deviation. And then going on from that, you need to make sure that you look at every single part of the QRS complex, every part of the ECG, to make sure that you don't miss anything. I don't know how devious your examiners are, but you really have to look quite carefully. So first of all, we've gone over P waves already, but there are just a couple of other things to know about P waves other than do they exist. First of all, their shape. So if you've got bifid P waves, what have you got?
Atrial hypertrophy.
Yeah, which side?
Depends which way round
Right.
the unit.
So if it's kind of an M-shaped P wave, left, P mitrale, yeah, left side. If you've got particularly tall P waves, which are, I think, more than 3 small squares each, what do you have?
People without
Exactly, and so by deduction you've got right atrial hypertrophy. Your PR interval is important because it should be between how many seconds, or small squares? 3 to 5, excellent. And then is it regular or irregular? Is the PR interval regular or irregular? And that will help you in defining blocks. So if your P wave is always behind your QRS complex, then you've either got sinus rhythm or first degree heart block. If it's not always behind there, it may not exist at all, or you may have a second degree heart block or a third degree heart block. But we'll go through that in a bit. If you have any questions, you can shout out while we're going through it, if you like. Q waves. I assume that you all know what I mean by Q waves, pathological Q waves. So it will look good if you can see Q waves. So basically they're signs of old infarcts, and look for them in the territorial distribution. So they've had an old inferior infarct, you can say, if they've got Q waves present in those areas. And the QRS complex. So how long should it be? Sorry? It should be no longer than 3 small squares, I think is what you said. And then you want to know if it's narrow or if it's wide. And if bundle branch block is present, if you've got the different complexes. So can anybody tell me what left bundle branch block looks like? What pattern you might see?
Yeah, you get a W and B1 and B6.
Yeah, excellent. I think that's what I've got down here. And then right bundle branch block is the opposite. And trifascicular block is right bundle branch block with left axis deviation and first degree heart block. So that's when you've got nothing going on. Excuse me. And so talking about ST segments, which are very important. So I've got up here the different distributions, different territories that you will see within the ECG. So 2, 3 and AVF are your inferior leads. V5, 6, 1 and AVL being your lateral leads, and then anterior V1, 2, anteroseptal / septal 3 and 4. So you'll need to look at your ST segments. First of all, is it elevated? Be careful with ST elevation because it can be infarction, which is the most important thing to mention and rule out. It can also be high takeoff. Sometimes you can get what looks like an elevated ST segment, but actually it's not, it's just high takeoff. And you get that after a really deep S wave. So if you go Q, R, and then really deep S, and you might have what looks like a raised ST segment, but it's high takeoff. And so the way to kind of distinguish is if they've got a deep S wave, and if it's concordant in those leads, so checking across your territories to make sure that it actually happens in each one of those leads. Depression, ischemia, and then it's always good to know which territory represents which artery is represented by which territory. So if they have an anterior infarct or ST changed, then it's to do with your left anterior descending coronary artery. If it's lateral, then it's your left circumflex. If it's inferior, then it's your right circumflex. So that's kind of icing on the cake, I think. Next, so your T waves. Excuse me. So what do you want to know about T waves? First of all, are they really, really tall? If they're tall and tented, then it might be hyperkalemia. In particular, it must be taller than the voltage meter. So the, what's it called? The bit at the beginning where the goes up and across and down, that bit there. I was told that the T wave must be taller than that in order to be called tented. But I think it's all in clinical context as well. If you're told that someone's got a potassium of 5 point something or 6 and they've got peaked T waves, then you can call them tented. And finally, I've just added something here about hypertrophy. So the difference between right ventricular hypertrophy, left ventricular hypertrophy, and what you're expected to find. So LVH, you get tall S wave in V1, so it's really, really deep. I've written tall and deep the wrong way around, haven't I? And a large R wave in this event. Ignore LVH and just go with RVH. That's correct. So tall R wave in 1 and a deep S wave in 6. Cool. So this is a systematic approach that I use. If you use it every time, you don't miss anything. Then once you spot an abnormality, to describe it. In particular, when you're working, it's important to look for signs of compromise and any related features. So if you see someone who's got a tachycardia, for example, for whatever reason, SVT, have they got signs of compromise? So are they now ischemic? If they've got AF, can you look for kind of related features of AF, such as digitoticity and that kind of thing? So I've got a few examples I thought that we could go through.
Got some chocolates as well.
Good, I bought sweets. So our first case, I haven't got a description for each one. It's kind of just go through and read the ECG and tell me what the most obvious abnormality is. So we've got a 32-year-old female who's treated for pyelonephritis. This is pretty much the ward. And she develops tachycardia and some chest pain. And this is her ECG. So who would like to present this ECG? Some chocolate. Anyone? Go on. You can say something.
Okay, yeah. So can't see the demographics, but we know that it's a 30-something-year-old woman, and we know she's got chest pain. So rate, looking at rhythm strip, there's about 2 large bursts from each one, so her rate's about 160, or maybe just a little bit lower than that. On her rhythm, she's got P waves before every QRS, and they look like they're about 2 small squares. So that looks fine, and the relationship to the QRS stays the same throughout the rhythm strip.
So therefore, what's the
Therefore, it's sinus rhythm.
in particular?
Oh, sinus tachycardia?
Yeah, perfect.
Yeah, okay.
That's what you say. That's the
Yeah,
one.
and then there's no axis deviation, and then I'd just be looking at each of the areas to look for any abnormalities. The T waves look normal. I can't see any QRS changes. I can't see any ST changes. So I think it's just sinus tachycardia.
Just sinus tachycardia.
Yeah,
Brilliant.
and then that would be in keeping with a possible PE.
So yeah, what are your differential diagnoses? So you earn yourself a sweet. Well done.
I'm not going to throw it because it might hit someone.
got a sweet head about it. So can somebody else give me, she's going to be armed with chocolates, can someone else give me top 3 causes of sinus tachycardia in hospitalised patients? Okay. Sepsis, good. She's got pyelonephritis, excellent.
Sorry, I didn't do that again.
PE. Oh, whoever said that, put your hand up, you earned a chocolate. PE is another one. PE is like such a common cause of sinus tachycardia. You barely ever see the classical PE changes. I've only seen it once, and the person died about 20 minutes later. So sinus tachycardia, I think PE. Any other causes?
Pain.
Pain, yeah, brilliant. If they're in excruciating pain, she's screaming out for morphine, she's going to have sinus tachycardia. Now, can you give me 3 more?
Anxiety.
Yeah, if she's having like a panic attack.
Cheers.
Chicken chocolate.
Caffeine overdose. We had someone in there and he did really caffeine overdose. Honestly.
Yes, if the nurses were plying her with coffee, then there's a possibility that she could have sinus tachycardia. And if I told you that she just bled 200 mils, you'd be thinking hypomania, shock, yeah, dehydration. Good. You go back about half an hour later, you've already given us some fluid, you've checked her temperature, you've done everything, and you've looked at her ECG, and now it looks like this. Somebody else, what do you think? Here's chocolate. Okay, so I'll give you 2 minutes to have a look at it, and then I want someone to present it.
S1 Q2T.
Could you present the ECG, please, in full?
The rest is going to do it for me.
Anybody want to? Sorry? Okay. Fine. Well, you found that it's S1Q3T3. Yeah, so she has got signs of PE on her ECG now, so she has got PE. However, when it comes to your exam, obviously you're going to have to present it.
Sorry,
using
I don't know what we're seeing at all.
Okay.
I got ECG teaching yesterday, and I was like, "Oh, what is this?" And she's like, "You'll never see it. You don't need to learn it."
You won't see it in, you'll hardly ever see it in practice, but if it's a slideshow exam in Leeds, it's come up in the past. So it's good to know it, and then at least it's not just for you to write down. But as an F1, you'll hardly ever see it. That's really right. But for your exams, it can come up.
So basically, going through it systematically, rate rhythm axis. Rate is sinus what is it? It's about 100 to 150. The rhythm is sinus tachycardia. Whenever you see a sinus tachycardia, a good tip is to look for S1Q3 T3, because it may well just be there, because common cause of sinus tachy is PE. So again, going through, looking at your P waves, they're not tented, they're normal, we've discovered that. QRS complexes are narrow. Looking for Q waves, well, there's a Q wave here in 3, which is our inferior lead. There's no Q wave in 2, there's no Q wave in AVF of note. So that's abnormal, first of all.
So the Q wave's downward inflections right at the start.
Yeah, excellent. Sorry, I should have said that. So Q wave is your first downward deflection of the QRS complex.
And if it's downward, then that's abnormal.
Yeah, so if it's more than, I think it's 2 small squares, then 2 small squares or more, then it's abnormal.
If it's followed by an upward one, because in V1 there's only a downward one.
In
Is that right?
V1.
With V1 there's a downward. Is that abnormal?
Yes, that is normal. You have a smaller R wave and deeper Q wave, I think, in V1, that's right. That R wave depression. And the R wave gets gradually larger as you go through the chest.
So how do you know that a V1 is a downward Q in V1 is normal but not in 3?
Is it worse to use it as soon as we're in
No, not 100%. just to refer to the book. Yeah, we can find out and put it online for you. Good question. And then, so sorry, we'll find out that and get back to you. Just going back through it. So looking at our QRS complexes, we've looked at the Q waves now. Now we're going to look at the ST segment, which, going through all our territories, the ST segment is not raised. So I'm happy with that. Now we look at T waves, going back through our territories. Normal T wave, inverted T wave in lead 3. Oh no, we've got a Q wave in T3. Pathological Q wave in T3. We've got a inverted T wave, so that could prompt us to look for an S wave in lead 1, which we've got here. So Q isn't really existent here at the moment. First upward deflection is the R wave, and then the negative deflection following that is the S wave. And then we go back up to isoelectric baseline, so that's your S wave there. So Q3, T3, S1, S1, Q3, T3.
Is it not normal to have that downward S wave then in the first strip? You know, lead number 1.
In lead 1.
Because that's got downward.
Is it that it doesn't come back up to the baseline? So like,
Yeah.
so it goes down, but it doesn't quite go back up to where it started.
It should get back up to where it started. We'll see what the next ECG shows. Yeah. Okay. So here's our next ECG to interpret. We're going to have a look at it and then present it. So, do we have any takers who would like to present it?
So this is an ECG running at about 48 beats per minute in regular rhythm. There are P waves before every QRS complex, and the PR interval is not prolonged.
Therefore, what's the rhythm?
So it's regular sinus rhythm, sorry, but bradycardia.
Sinus bradycardia rhythm.
And then the QRS complexes are distorted in some of the leads, showing ST elevation in 2-3 ABF and reciprocal ST depression in V2, V3, V4, and also AVL. So that's consistent with an inferior MI.
Yeah, perfect. Well done. Yes, it's consistent with an inferior MI, inferior in particular ST elevation MI. So, how are you going to manage this patient? He's just come into you, he's a 68-year-old guy called Fred. He's in the emergency department right now, he's got chest pain. This is his ECG that you've just done. That's been faxed to you from the ambulance crew, so you're just about to see him. What are you going to do for him?
Morphine, oxygen, aspirin.
And
Get them to, it's ST elevation, so you want to get them to that.
yeah, so MONAC and PCI. This is an emergency situation, so you'd also want to talk about ABCDE. So you'd start with A, make sure that their airway is painted, give you some oxygen, part of pneumonia, and then the rest of it. Don't forget to mention the blood tests that you would do, and you can talk about troponins as well. And I think that will deserve some chocolates for that. Should we start having that? Thanks, well done. Okay.
No, wait, yes, I got it.
So this is our next ECG. Would anybody feel confident in presenting this? Or like to have a go? I think we'll have to go a little bit quicker because we've got a few more things to cover in the session.
They've got S2.
So can I just have one person and kind of get them to present it? Or if you want to divide it into two, do
And
both.
so is it early take-off?
You need to present it then.
See what the most obvious answer.
So just do rate rhythm axis. The most obvious abnormality is.
Okay, so the rate is about 150. Yeah. Sinus rhythm.
Yeah. So in particular, sinus tachycardia.
Sinus tachycardia. No axis deviations.
Do you think? I think, yeah, it's mostly upward going too, but I think the interview is very strongly negative.
Yeah. Did you look at 3 as well?
Yeah, I always check using 3.
Check you do 3.
Use ABF as well, don't they?
Yeah, you use it. Cool.
And then I don't know whether it looked like it was, is it got early take-off?
Early takeoff. I don't have a picture of early takeoff on here actually, so this isn't early takeoff. Reason being, because I want you to have a look at the isoelectric baseline between the S wave and the T wave and tell me if it's normal, raised, or low. And then I want you to have a look at the territories and see if it respects any of the territories, and if so, which ones. No. So what we've got here is saddle-shaped ST elevation. If I say saddle-shaped, what do you think? Pericarditis, brilliant. So he's got ST elevation, not only just in lead 2, 3's not massive, 3's not huge, a little bit in AVF, so inferiorly. He's also got it anterior, lateral, so it's everywhere, so it's pericarditis and saddle-shaped. Well done.
Sorry, can I just ask, so
Yeah.
ST elevation everywhere, pericarditis.
Yeah, so if it doesn't respect the territories that we spoke about earlier.
Yeah.
So yeah, if it's kind of diffuse ST saddle-shaped elevation, then it's pericarditis. Okay. Have a little look and tell me what you think.
So the rate's about 96. The rhythm is irregular, so this is a regularly irregular.
Okay, so what's the rhythm? Are there P waves?
There are no P waves, I don't think.
So what can you comment on the rhythm?
So it's not sinus.
It's not sinus, no, but what is it?
Atrial fibrillation.
Fantastic. So I was pushing you there because
Can you
you're
say-
allowed to say regularly irregular when you're feeling a pulse, but you're not allowed to say that when you look at an ECG.
But so you say you're almost saying the diagnosis is part of your rhythm.
Yeah, because atrial fibrillation is in the rhythm. Yeah. So you could say here atrial fibrillation. That may well be the most obvious abnormality in an ECG. So having a look at this ECG then, so we've got somebody who's got AF. Is there anything else that you can comment on? What's that? Where's that? Where's the T-wave version? Yeah. Brilliant. What do you think that might be?
Posterior.
Okay. They're not in pain. No, they're feeling a bit sick, but they're not in pain. Digoxin toxicity. Well done. These are reverse tick ST depression, reverse tick TA conversion. And I thought it was demonstrated quite nicely here. You can see them here in V5 and in V6. So another trick for your kind of data interpretation exercises is if you see AF, first of all, is it fast? If it's really, really fast, is it compromised? I.e., have they got ischemia going on? If it's normal, always have a look at their T waves and see if they're inverted, because the answer might be digoxin toxicity. Brilliant.
Sorry, are the T-wave inversion, is it in any particular place? Is it typical to be in V5, V6? Or is...
I think it's possible that it could be in play. I think it was just clearly here in V5 and V6. I'm actually just going to skip over this one. I'm probably going to skip over this one as well, just for the sake of time.
Yeah.
I might do this one and one more, and then that's it. And then we'll move on to ABGs. So, before you say that, I'm going to circle my mouse right here. But nice thinking. Go through it systematically. Rate rhythm axis.
PR intervals.
First degree heart block.
Exactly. The person has first degree heart block. Have they got anything else?
What's going on V1?
In lead one.
V1? Is that normal?
Yeah, that's the one.
That looks weird.
I have got a book we can consult it.
Yeah, that's normal, yeah. Very. Yeah.
Cool. So this is first degree heart block.
No,
Is
not
it
really.
problematic? Do you need to do anything about it? No.
Yeah.
Unless they've got left axis deviation and all sorts of bundle branch blocks. But they haven't, we're happy. Good. Any comments on this one? So there are two abnormalities on this ECG. Going to be nice. So, rate. What's the rate, everybody? Did someone say ridiculously slow?
About 48.
About 48. So they've got bradycardia. What's the rhythm?
Irregular.
Regular.
So what's the rhythm? How do we work out what the rhythm is?
8 times 6.
What's the P wave? Is it related to QRS complex? If it isn't, is it regular? Is it irregular?
It's regular.
When you're commenting on rhythm on an ECG, you have to comment what the actual rhythm is. So is it AF? Is it heart block? Is it sinus?
Oh, heart block.
What kind?
Second degree.
Second degree. Any takers? Anybody want to agree second to third?
Maybe it's one.
Second degree.
Second degree.
Maybe it's one.
Maybe it's type 1. Brilliant. Well done. Girl of the stripes. Well done. So it's maybe it's type 1, secondary heart block. And any other abnormalities? Can everyone see that?
No, I can't see any P waves.
You can't see P waves. So we've got a P wave right here. And then the PR interval prolongs. Can't quite see it, I think it might be here. And then we've got a P wave, and we've missed a QRS complex. Then we've got a normal P wave QRS complex. And it starts to prolong. It gets, I think it's about here, it gets even longer still, and then we've dropped a beat again. That's when we're back. Well done. Did anybody spot? So this is our second abnormality. but we've already done ST elevation, so I'll let you off. Can you just tell me what the territory is? Anteroceptal. Yeah, brilliant. Cool. And this is the last one. Who said that? So what did you say? Oh, okay. So what's the rate? Quite difficult to tell, isn't it?
It's 90. It's 90.
Brilliant. Rhythm.
Is that P wave bifid? To you?
Is that a bit?
No, it's the T and the P next.
On the rhythm strip.
Yeah, this is a very abnormal ECG. Now, is that a P wave? I think actually, this here is the P wave. This is the Q.
Oh.
Right.
A nicely slurred QRS complex and so if I circle here, this one, no, massive T wave. So we've got really abnormal ECG. Does anyone, I don't know if I'm allowed to say this. So there was a revision course that a lot of people at my university attended last year, and there was a little dance about hyperkalemia. So,
Do it.
flat, I don't know the dance, I didn't go. We got flat P waves, flattened. We've got slurring into the QRS complex, wide, broad, abnormal. We've got really tall tinted T waves. So this, my friend, is brilliant. So this guy's just come into the hospital. He's had a long lie. He's been on the floor for about 3 days, and he's really dehydrated and not feeling very well. He's pretty much unconscious. What are you going to do for him?
ABCDE.
Okay, so thank you. A. Brilliant. And then what are you going to do?
Try and correct his hypokalemia.
Okay, how are you going to correct his hypokalemia? I want everyone to try and give me one.
So 10 mils to 10 mils of calcium gluconate to check
Yeah.
myocardium.
Perfect.
You're then going to give 50 mils to 50% dextrose with insulin.
How much?
10 units.
10 units, I hear. I'll take 10 units. Yeah, brilliant.
And so you're nebulizing levels back to back.
Brilliant.
Okay. And then some calcium retain.
Excellent. If he starts to come round and can swallow, then we'll give him some calcium retaining. Well done. Good. You all know your management of hypokalemia. Excellent. And you're also going to check his calcium regularly using a venous scan to make sure that your treatment's working. Fantastic. What are you going to do to this one? Good. And so, yeah, 222. Good. Okay, so that's. I just picked over the last ones for time. Okay. Hi guys. I'm gonna. My name's Ted. I'm an F1 respiratory at the moment. I'm going to quickly breeze over ABGs with you guys. I'm sure you guys have had lots of practice with them now, and so you probably know all about it. Okay, so really simple 5-step approach of interpreting ABGs. The first thing that I always do is assess oxygenation. The last thing I want to do is interpret an ABG and then go to the consultant to ask for help, and they'll ask you how much oxygen are they on, and you don't know. So the normal range for oxygen is above 10. That's just the cap, basically. But what you need to know is the patient hypoxic or not? That's the most important thing. That's your A, basically, in your ABC. Are they on any supplementary oxygen? Because if they are, then obviously that affects your ABG results. You need to make sure. Let's say if they're not on any oxygen and their oxygen is 6, then obviously you need to give them. Well, what do you need to give them? Like it's 6 or something. If they're just hypoxic. How much? You wouldn't give them 15 litres of hypoxygen straight away because they're very, very hypoxic. If they need to be more than 10 and it's 6, then that's quite bad, isn't it? You don't think about anything else beyond that because, yeah, there's lots of issues about hypoxic drive, and we'll talk about that a bit later, but they will die from hypoxia before their carbon dioxide retention. So I won't worry about that. Next thing you need to do is determine the patient's pH. So your alkalemic if it's above 7.45 and acidotic if it's below 7.35. The ranges do vary in different hospitals, but in Leeds THD it's these, and in your OSCEs it would be these. Then you need to determine the respiratory component. So it's not CO3, it's CO2. Massive error there. But anyway, just check their carbon dioxide levels. And if it's above 6, then you're thinking about respiratory acidosis. It's below 4.7 in these, it's 4.7. You think about alkalosis, okay? That's the other way around. Okay, that's fine. And then metabolic, so you're looking at your bicarbonate, and that's between 22 and 26, which I'm sure you all know. And I haven't put base excess on here, but a lot of people look at base excess as well. You should look at base excess, because you want to see that if somebody's if their bicarbonate is 26 and above, then you want to see if their base excess is high as well, because then it's corresponding to a metabolic component. And then you combine all those points to find out what the primary disturbance is. Because I think the main confusion is you look at the pH and then you look at the carbon dioxide and then the bicarbonate, and they're all deranged, and you think, crap, I don't really know what to do. But it's all about pattern recognition, so you want to see which one's more deranged in the context, in the clinical context of the patient as well. And then, after you've done that, then think about compensation. I think lots of people get really confused about compensation. So when I say this patient's compensating, what does that mean? Okay, so if I'm a patient and my pH is 7.2 and my CO2 is 6 or something, so what have I got just with those two? So if you think of respiratory acidosis, so if I say to you that this patient is compensating without even telling you their bicarbonate, what are you thinking about? What is happening?
High red.
They've got high bicarbonate.
Yeah, their bicarbonate is high, would be high. Why would it be high?
Get rid of the acid.
Yeah, so in acid-based disorders, what's happening is if it's a respiratory component, then they're not being able to block their CO2, they're retaining it. It's causing more carbonic acid buildup, and that creates your pH to decline. Okay, and what your kidneys are doing is trying to compensate by trying to keep as much bicarbonate and not excreting it. That's it. So what do you know, how can you differentiate between partial compensation and full compensation?
If the pH is normal.
Yeah, that's the only way to differentiate. If the pH is back in range, but your CO2 is still crap and your bicarbonate is even worse, it's fine, because your body's trying to get your pH, your blood's pH back to normal, and that's the main thing that you're worried about. Okay. So stick to the basics. I've got a few tables in here, and just use these tables for your OSCEs and for your integrated, and you're almost guaranteed to get a massive EMQ on acid-based disorders, because they can't pretty much every year. So yeah, respiratory acidosis. So if CO2 is going to be high, that's your main problem. The alkalosis is going to be low, and metabolic, your bicarbonate is going to be low, and your if it's alkalosis, it's going to be high. Simple as that. Okay. So, causes of respiratory acidosis. Go. Anything? Type 2 respiratory failure. So what is type 2 respiratory failure? Is it, so if you just retain carbon dioxide, then is that type 2 respiratory failure? Yeah. So you have to have hypoxia as well as hypocapnia. You have to have both to have type 2 respiratory failure. But that's a secondary component, isn't it? Something is driving the type 2 respiratory failure. So what would be driving?
Alveolar hypoventilation.
Respiratory
Yeah,
depression.
COPD. Okay, simple as that. If this is your exam, if this is your OSCE, it's sticking to basics. Even as an F1, no one's going to say to you, describe alveolar hyperventilation. You want to say this is COPD, okay? What else? What else would you get in respiratory acidosis? Yeah, pneumonia. So many patients come in with acidosis, absolutely type 2 respiratory failure. Why? Because they've got a curve 3 pneumonia, and they've come in onto the respiratory unit. What else?
Pain.
Respiratory depression in morphine excess.
Yeah, that's a good one. I haven't written that. So drug induced. Yeah.
Pain.
Pain. Acidosis.
If they weren't breathing after like an operation or something, and so they're not breathing properly, so they're not blowing up their carbon dioxide.
Yeah, okay, but generally, no, I understand what you're saying. So, yeah, I guess that can work. You can get, I've never seen somebody go into respiratory acidosis, but that's an absolutely valid point. That is an absolutely valid point. But with pain, you tend to get tachycardia, you tend to hyperventilate, and you can go into respiratory acidosis. Okay. But the other thing was to think about neuromuscular diseases. So, do you know any?
MS.
Yeah, MS. Julian Barr, and then the myasthenia. They're your main ones. A lot of patients that have scoliosis or kyphoscoliosis, or if they have like cerebral palsy, will have, they will be CO2 retainers. Okay. And then pneumothorax composite as well. Okay. Alkalosis? Yeah, your main reason is hyperventilation. A lot of patients that are in pain can have hyperventilation, and that can be a driver of it. Is there anything else, other primary sort of diagnoses in not respiratory related, that can cause you to hyperventilate?
Anxiety.
Yeah. Yeah, anxiety is one of the main reasons. It's typical. You get sort of a 40-year-old lady coming in, and she's alcoholic, no respiratory history, and she's just suffering from an anxiety attack. Toxicosis can cause it as well, just because of, again, they're hyperventilating. So all of them really is got to do with hyperventilation. And sometimes when you've got pneumonia, I've seen a patient on the ward that actually presented with respiratory alkalosis. Okay, but that's not as common. It's more acidosis that they come in with. Cause of metabolic acidosis? Yep. AKI, one of the most common causes.
Drug overdose.
DK, drug overdose. Yeah. Anything else? Salicylate poisoning. So in salicylate poisoning, you can also get respiratory alkalosis from that as well, because you're hyperventilating. It's a reaction from the salicylate. But you get metabolic acidosis as well, and drug-induced is a big thing. Refeeding syndrome, Eleanor was telling me about it, so that's when you think about refeeding syndrome, you can get metabolic acidosis because of all your low electrolyte levels. Yes. Alkalosis?
Diarrhea and vomiting.
Yeah, that's one of the most common causes. What else? Sorry? Yeah, you can. I haven't put that down. That's a good shout, yeah. I've never seen it, but okay. So the main stuff is if they're on diuretics, if you just drive someone's kidneys and you just push them with things like furosemide, then they could go into metabolic acidosis, and a lot of the time it's all iatrogenic. And hyperaldosteronism can cause it as well. What's a syndrome? Cons, yeah. So I think the mechanism with that is really, it's got to do with your sodium and hydrogen pump. It's retention of, it's getting rid of the hydrogen ions that causes you to turn into metabolic alkalosis and high sodium levels. Okay, but I don't think anybody will ask you about hyperaldosteronism. But if you mention it to a renal consultant, they'll be really happy. So, scenario, are you going to be am I going to be the nurse?
Yeah.
Can you come on? So we're going to do act out a scenario for you guys. Just because this will be something really common, you'll get this on your surgical on call as an F1 on your second night shift or something. And then the second one, we'd like a volunteer to do it. That's all right, and I'll be the nurse. Okay. So if I'm the you're the doctor. Okay, so I'm calling you now. So I've just bleached the. I'm one of the nurses on the
surgical ward, and I've just bleeped the on-call F1. So I've just called you.
Hello, surgical F1.
Hi, is this the doctor?
Hi, yes, who's speaking?
No, is this the doctor?
Yes, this is the F1 on call.
The house
The
officer?
house officer.
Oh, right, okay. Can you please come and see the patient, please?
Yeah, where are you calling from?
Ward 2.
Okay, and can you tell me who the patient is?
It's Mr. Bob's your uncle.
Okay, and is he, what's the problem?
He's really unwell.
Okay, is he breathing?
I think so, yeah, of course, yeah.
Is he awake?
I haven't really checked again since I did his obs.
And was he awake when you did his obs?
Yeah, he wasn't talking to me as usual, but I think he's really unwell. I'm really worried. I don't know what I'm doing. I think you should come and see him now.
Okay, can you tell me what his early warning score is, please?
What?
What are his obs?
Okay, so his pulse is 110.
Yeah.
His blood pressure's 72 over 45. But that's not that bad, I don't think, because it was about 80 before. His stats are 92. I think he's on it. I don't think he's on oxygen anymore. And his urine output's pretty good, actually. It's 50 mils now.
Okay, over how long?
6 hours.
Right, okay. So he's really not very well. So I'm going to come and see him, but I need you to just do something in the meantime.
Oh no, but you have to come and see him because I can't take orders over the phone.
Okay, I want you to put some high flow oxygen on him. Has he got a cannula?
No, he doesn't.
Okay, I'll be over right away. Can you put some high flow oxygen on him and redo his obs when I arrive, please?
Okay.
Thanks.
Okay, so this. I'm not over exaggerating. That's what some of your nights will be like. Like whoever is on the other side of the phone will be talking to you as though they are like they're a high school student or something. Like they have no idea what they're talking about. Sometimes you'll get a healthcare assistant calling you. So, I mean, they're all doing their right jobs and stuff, but you know, sometimes they're really anxious on the phone. They've got 20 patients to see. You might have a patient on the ward that you're on already with a news of about 12, and they're calling you saying this patient's unwell. That's not enough details at all. So what Eleanor did was absolutely right. You need to ask, the key things you need to ask them, is the patient, the first thing I ever say is the patient dying? Do you think the patient is dying? Are they breathing? That's a really good question. Are they conscious? And obviously you want to know what their news, their early warning score is. Because in any situation, and this is for now and in the future, if the patient's muse is beyond 6, if it's like 9 or something, yes, you need to go and see them, but you need to also tell them, call critical outreach, because by law, they need to know about it. Call the reg on call. They need to know about it. If in between that time, you weren't able to see that patient because you were dealing with somebody who needs at 12 or something, then you can be liable for not seeing them or not contacting anybody else. That's your head. Okay, so back to this. What are you going to do? So now this is you in the scenario. What are you going to do? You know, these are the obs. They're very hypotensive. You've done your ABC when you go there. What are you going to do? You're going to give a fluid challenge. How much are you going to give?
500 mils stat.
Stat, okay. What are you going to give?
Anything.
Yeah, anything. It doesn't matter. You know, give him saline, give him Volplex, whatever you can get, give it straight away. He's already on high flow oxygen. What else are you going to give him? What else are you going to do, really? Yeah, you want to start getting
Think
more
about
about.
the
You want to
core.
listen to his chest. You want to see what's going on. You want to you want to look at his obs again because he's on high flow oxygen, but his stats are 92 on air. It's not that bad. So what you can do is you could think, actually, it's not that bad. Let's see what his obs are. If his stats are picking up, let's change it. Let's put him on a nasal cannula or a face mask. It's fine. He's not that hypoxic. What are your normal levels of FiO2 on a normal patient that doesn't have any respiratory conditions? Above 94. So BTS guidelines 94 to 98. If it's me, normal patient, or if it's somebody that has COPD or a CO2 retainer, it has to be 88 to 92. Okay, so the main issue in here is he's hypertensive and his urine output is absolutely crap. So what you want to do is push fluids as quick as you can, reassess. You want to do all of his bloods. So what bloods do you want to do? What do you want to find out?
ABG.
Yeah, you need to do an ABG. Okay, so let's move on. So this is his ABG. So he is still on oxygen. You've switched him down. He's on 40%. What can anybody describe this ABG to me?
Acidosis.
Why?
Because he's acidotic and it's because of the bypass.
Yeah.
And he's also got type 1 respiratory failure and very negative.
So what's happening?
Trying to compensate.
Yeah, he's trying to compensate for it. Is it full or partial?
Partial.
Yeah, because he's still very acidotic. Now, you'd never see this patient on a normal ward because it's 7.1. It's probably what needs to happen with this person. They need to go to HDU, ICU, or RCU. If it's Jimmy's, they will go straight to respiratory reg on call, and they need to have. What do they need to have? What are you going to do now? You're the F1. You're on your own. This is the ABG. Your reg isn't answering. The consultant's asleep. Your SHO is busy with the news of 12 somewhere else. What are you going to do in the time that you have?
Yeah, just treat him like.
Yeah, you can do. But so you've called the anaesthetist and you've told ITU that there's this patient, they're really unwell, they need to be transferred. There's two things that you need to do in the meantime. Sorry?
More fluid.
Yeah. What else? Three things. What else?
More oxygen.
Yeah. Yeah. You want to manage the airway. I wouldn't.
So you just let the acidosis recorrect itself?
No, the thing is, it won't recorrect itself that quickly. You're giving him fluids anyway, okay? But what you want to do is you want to call, because you can't make that decision on your own. This patient is really unwell.
Sorry, I'll rephrase. Theoretically,
You
bicarb
can give them
help that
bicarb.
acidosis?
Yeah, but it will still take a while. It won't correct straight away. So what you will do is you will say, if this was your OSCE, I would medically manage this patient. So you've given fluids, you give them oxygen, you'd redo the ABG half an hour after you've changed the oxygen levels because it takes about half an hour. Okay, you'd make sure they're having half-hourly obs done. Okay, you'd also check their BN. Okay, and you would call critical outreach in view of escalating this patient to ITU because you can't directly admit somebody to ITU. They have to go through critical outreach, and they are on call as well. Okay, and this is the situation you'll be in. Eventually, what do you think this patient will need? Sorry? Yeah, non-invasive ventilation. Have you all heard of BiPAP and CPAP and all this stuff? So this patient would need BiPAP to get rid of the CO2. Okay. Second scenario. So does anybody want to be my doctor if I'm the nurse? Anyone?
Yeah.
Go on. You always got.
No one else does.
Okay. So I'm the doctor. I'm the nurse.
You have that.
Okay. So I'm going to need you now. So I've just.
It might be annoying, and let's just go back to the previous one. We're just a bit confused because you said it was a respiratory acidosis.
No. I said it's metabolic acidosis.
That's fine. That's okay.
Yeah. But I was saying if it was respiratory and their pH, sorry, I wasn't so clear. If it was respiratory and their pH was that low, they would need an IV.
That's okay.
Okay. So, you still happen to be my doctor?
Yeah.
Okay, so I'm calling you, ring me.
Hello?
Hi, is this the doctor?
Yes, this is Andrea in F1.
It's who?
Andrea?
Andrea, okay. Hi, how are you?
Yeah, I'm okay, thanks. How can I help you?
Are you busy?
I'm a bit busy, but what's the problem?
Where are you right now?
I'm on MAU. Where are you? Who are you?
Right, okay. Come and see the patient, please.
Where are you calling from?
I'm calling from MAE on the other side of the ward.
Okay.
Come and see the patient, please.
Yeah, which patient?
It's Mr. Smith. He's really unwell.
Okay, what's wrong with him?
Well, basically, he's been vomiting. He's confused. He's walking around without his gown on, and everyone's getting scared.
Okay.
I don't know what to do. He's just. Well, I don't know what to do. Can you just come and see him, please? Because I'm going to go on break in about 5 minutes.
Do you have some odds on him?
Yeah, I have actually. So his pulse is 115 miles per minute. I've had somebody say that to me on the phone. His BP is, his blood pressure is 85 systolic. His respiratory rate is 22. His SAT's 96 on air, and his urine output is 15 mils in the past 5 hours.
Okay. Yeah, I will be across the board any minute now. Can you try and...
What do you want me to do in the meantime?
Can you try and sit him down if he's wandering around with his blood pressure that low? Do you know if he has a cannula?
Yeah, he does have a cannula.
Okay, can you get some fluid ready for me for when I get there?
Yeah, but I don't know because it is old. The cannula's about 2 days old, 3 days old now, so he'll need it changing.
Okay, can you get a new cannula set ready for me?
Okay.
And some fluid, and I'll be there straight away.
Okay.
Thanks.
Someone's ought to have a word with that nurse.
Sorry?
Someone's ought to have a word with that nurse.
I know. So basically, this is really bad. I'm just absolutely nailing it. Okay, it's not actually that bad, but I have had somebody say to me the patient's pulse is 100 miles per minute. I'm like, what are you talking about? So this patient. So the things that you want to ask them. So if you now were not an ME, but if you were somewhere else and you were dealing with a patient who was worse than this, and let's say your reg is there, you can obviously ask your reg for advice, but you would need more information from the nurse. So you could also ask, what did this patient come in with? And then, grab the patient's notes. I'm still on the phone. Tell me what they came in with, and they can tell you they came in with vomiting. They had vomiting for a day. They're confused. What's their past medical history? Are there any medications? What else is going on? Tell me everything you know about the patient. It buys you time to think about what could be the possibility by the time you get onto the ward. So already you know what you're wanting to do. The last thing you want is you're in a stressful situation. You have no idea about the patient. They're musing at about 15 by the time you get there. And the last thing you can do is go through the notes and have a look at what
So
the
do you think
situation
you've got time to get all that information when their BP is that low?
Yeah, you do. So if you say to them, so in that scenario, I would say, okay, how old are they? What do they come in with? And how were they earlier today? Because if they were fine, then you're thinking, oh right, so what could be the possible causes of them suddenly dropping their BP? If they, like the previous patient, had just come after surgery and they didn't tell you that, then you wouldn't know. You could think of things like, so what would be the previous case, we'll just go back to that for a second, what could be the causes of him dropping his blood pressure so quickly after surgery? Bleed. Yeah, and sepsis. So they're the main 3 reasons, and already you can start saying, okay, take the blood cultures, pack it out, get the cannulation trolley ready, make sure you've got the fluid set up, and I will prescribe everything by the time you get there. And we've got really good nurses. By the time you get there, everything's already there. All you need to do is prescribe and start things going. But if you don't even know anything about the patient, then it makes it really difficult to know what's going on when you get there, and then things get a little bit more hectic. And sometimes you bump into your reg, or you manage to speak to an SHO in the way, on the way there, or if they're already there. And if you don't know anything except their news, then that's pretty crap. Okay. So what are you going to do so far, after you've done all that? What bedside test are you going to do?
ABG.
So what's going on with this ABG?
Metabolic acidosis.
Yeah, it's another metabolic acidosis. Is he compensating?
Not really. A little, yeah.
Sorry, is the basis 11?
Yeah, the Bible.
Actually 11.
What's the level of the
Yeah. What's the CO2? Is that normal?
Yeah.
Yeah. It's not. So they're not compensating. I think in a real case scenario, they would probably be compensated with a pH of 7.2. But this is just to make the point that this person's not compensating. So what do you think would be knowing this ABG and looking at the scenario? What is the main driver of this patient's metabolic acidosis in this situation with this information alone? Why? Yeah. What else?
End stage.
So yeah, exactly. So all of this is AKI, but what is the cause of his AKI? Well, most likely the cause of it is actually this guy, 62. Yeah, I can use him for vomiting, but he has had lots and lots of ibuprofen. He's had it PI prescribed, which you'll find quite a lot of the time. And he's on it regularly, and you'll notice that he's actually getting a lot of NSAIDs and ACE inhibitors as well. So if you had a drug chart in front of you in your OSCE, what would you do? It comes out every single thing that contributes to that patient's AKI. And you will have lots of scenarios in your OSCE where there'll be some sort of crossing out of any medications that contribute to AKI, just because they're a little bit evidence. Okay, so this is a summary. I don't think all of it. You can't see the bottom slide. You can't see the bottom. You can't see mixed alkalosis. Sorry, it's a big table. But I literally, for my OSCEs, learned this table inside out, and for integrated actually, because you can get a really big NCQ or EMQ with lots of scenarios. And if you know this, then you should be fine. Okay, I won't go through each one, because it just gets really boring. Okay. So, chest x-rays. We're really running out of time, so I'm going to be really quick with this. You've done this in third year, it's exactly the same thing. Even in ECGs, the correct way of doing it is going through every single point. So you want to go through things like, so for chest x-ray, you want to make sure you know what type of film it is, if it's PAAP, whereabouts it is in the body, demographics, when it was done, where it was done, check the adequacy. So quickly, rotation. How do you know if it's rotated or not? Exposure. Yeah, vertebral bodies and what else? You can count the number of ribs as well. Sometimes, especially on respiratory patients, that's a really crap measure. I usually just look at the vertebral bodies. Inflation, how can you check if it's inflated?
Can't influence.
Yep. And position.
You should be able to see everything.
Yeah, you should be able to see everything. It's a rubbish X-ray if you can't see, if chest X-ray, if you can't see the shoulders and you can't really see the gastric bubble, or at least both sides of the bubble. Mention the obvious. As a final year, you won't, in your OSCE, you probably won't have time because it will be just after a respiratory station. If they've changed anything, it may be a separate station. In that case, go through everything systematically. But if it's just, here's a chest X-ray after your respiratory station, what do you think? Say, okay, this is a chest X-ray of Mr. Smith, who's 72 years old. This is a chest radiograph. It's an AP film. The most obvious abnormality is he's got a tension pneumothorax. And then if they want to ask you any more questions, they will ask you. But at least if you run out of time by then, you've got your marks. In practice, in reality, you have lots of time on the ward to go through everything. And then, so this is the order I do it in, and I prefer it. Mentioning what external materials, so what types of things can you see on a
Pacemaker.
Yep, pacemaker, energy tubes.
Valve replacements.
Yep, valve replacements. Central lines, stenotomy wires. See if they've got oxygen on, if they've got E-rings in, if they've got a bra on, see all that. Okay, trachea, we want to make sure it's central. Mediastinum, why is it really important to check mediastinum? Two main things. And
Polyomegaly in half it.
yeah, what else? It's not going to kill you very quickly. Yeah.
We said that.
Yeah. And what else? Yeah, dissection can as well. Both halves, so when your esophagus perforates. That's really bad, and that can cause a wedging mediastinum. Okay. Heart, so what you're looking for around the heart, generally, main things. size,
Borders.
ratio,
Borders.
borders. Okay. Highland?
Levels.
Levels. Remember, left is always higher than right. If it's the other way around, you're thinking of things about like collapse, okay? Because it will push, if it's a low collapse, it can push the Highland upwards. Just the way it works. Because what's happening, if there's a collapse anywhere else, the rest of the lungs are trying to compensate for it, okay? Diaphragm. Main thing is look for free air under the diaphragm. What is that a sign of? Yeah. Lung fields. These are the main things that you're looking for. Okay, so for shadowing. What a sign of air bronchograms?
Consolidation.
Main thing is consolidation. Meniscus.
Diffusion.
Yeah. Pleural effusion. Reticular shadowing. Fibrosis. Why are you looking for lung markings? Pneumothorax. Pleural plaques.
Mesothelioma.
Asbestosis. Brilliant. Kelly B lines. Brilliant. That's good. Okay. So, lung fields, you're looking at the costophrenic, cardiophrenic angles, and then I look at lung fields and heart borders together because depending on where the consolidation is, or if it's a collapse, you can get obscuring of different heart borders, and we'll go through some chest x-rays really quickly. Okay? Look at the vessels. So, when do you get upload diversion?
Okay.
Brilliant. And don't miss the edges. Go around all of what I do is go in, outwards, so look at the heart, look at Highland, the lung fields, costophrenic, cardiophrenic angles, and then go all the way around to the chest x-ray to see if there's, because if there's a small pneumothorax, you will miss it. And then at the end, look at soft tissues, bones, fresh shadows. Okay. If it's a respiratory station, don't worry. You don't need to worry about those things, but obviously you should know about them. And then present your findings coherently. The main thing is this is a 62-year-old person. This is a 62-year-old gentleman that's come in with, I don't know, cough and shortness of breath. They have had, this is a AP chest radiograph or chest film, which shows right lower lobe consolidation. That's it. That's all you need to know. Okay. This is these findings are inconsistent with community-acquired pneumonia. Yeah, that'd be really straightforward. Okay, some really quick questions. Really got time. How should it normally be taken?
Standing up on inspiration.
Yeah, standing up on inspiration. Main thing. What are the problems with a supine film?
Rotation of inadequate inspiration.
What else? Yeah, you need to erect chest x-ray if you want to see if there's perforation. So free air of the diaphragm, you always say erect chest x-ray. Okay. What can cause deviation of here? We've already talked about that. What else?
Collapse on
Massive collapse. What else?
massive effusion.
Yeah, massive pleural effusion, like a malignancy, can cause it. A mass can cause it as well. Two main causes of lymphadenopathy. Sarcoidosis. TB. Okay. Raised hemidiaphragm.
Fibrotic lung.
Yeah, fibrotic lung is the main one. Okay. Alveolar shadowing. Somebody said something about heart failure. What else?
Pulmonary edema.
Yeah. Well, pulmonary edema, heart failure. What else? You get it into pneumonia as well. Okay. Cause of reticular shadowing. Fibrosis. Okay. There's lots of different types of fibrosis. So what else can cause fibrosis? Yeah. What can cause interstitial lung disease? What other things can cause it? Yeah. What's something that's really common in a lot of patients that don't have respiratory history? Yes. What was that? Radiotherapy can cause it. Rheumatological patients can have reticular shadowing because of.
Fibrosis.
Yeah. But why? What's driving their fibrosis?
Systemic sclerosis.
Systemic sclerosis. What else?
SLE.
Seronegative.
Rheumatoid.
Yeah, rheumatoid. So if they've got rheumatoid arthritis, no respiratory history, and they're on methotrexate, okay, that can cause it. Examples. What's that? Pneumothorax. Where is it? Where is it?
Right, on the right.
Yeah, right. So you want to say right pneumothorax. You won't get too much. It's fine, it's fine. But if this is just a slideshow and you didn't put right, then you'll only get one mark. It's as simple as that. Okay, this one? I can't see it behind me.
Right zone consolidation?
Right?
Oh,
Mass
no,
left apex.
yeah. Left apical mass.
Yes. What else?
This.
Look at both the lung fields and try and compare them. What else are you looking at?
Right mid-zone opacity.
Yeah. So there's a problem there. Oh, you can't see what I'm doing. So there's a problem there anyway. But the main problem with this patient would be the left apical. So what are the causes of that person to be
Pancreas tumour.
Pancreas tumour
Or TB.
Or TB. Okay. We'll circle this one, but so this patient has something which then led to something else. What could that possibly be?
Mass.
Yeah, so it could be a cancer, couldn't it? And that is a
Pleural effusion.
it's a pleural effusion because of the
Meniscus.
meniscus. Okay, it's fine. If that was big enough, would it push or pull? Push. What's going on here?
COPD.
That's flat.
Why is it COPD?
Pressure related skinny mediastinum, flattened diaphragm.
Yeah.
Right, middle,
What else? Yeah, you said that. Yeah. This patient, why do you say it's got a low back collapse? Yeah. Can you see that? I don't think it's projecting very well on there, but it will be if he's got a low bar collapse. So he may have, he's got a flattened diaphragm, given, or he, in this case actually, but it's actually a right low bar collapse. Okay, you're looking at the heart border.
Is there left as well? Because there's a double heart border on the left hand side. So some sort of left collapse.
It's a bit difficult. No, I don't.
If you give it, there's another picture that would be.
Oh, is there another one? Oh, I need to know, sorry. So what sign is this?
Sale sign.
Sale sign. So he's got right, and then, so what type of collapse would this be?
Left lingular.
Left lower lobe collapse. What's this one?
Right, middle lobe.
Yeah.
Because
Right lower lobe. Right middle lobe. Right lower lobe.
take us right lower lobe or middle lobe?
Right middle, because you can see the heart border.
Lower. You can't. This is a bit of a difficult one to be honest, but it is a left. It's a right lower lobe collapse. If it was middle, you wouldn't be able to see that whole heart border that you can see. Okay. What about this one? What is that? What's that? I didn't see that. Anyway, look back. What's going on here?
Yeah, paratracheal stuff. Nodes.
What did you say, sorry?
Paratracheal nodes on the right hand side.
Yeah, he does have that.
Right.
Certain colours looking at that.
Probably causing.
But it could be probably causing this. Yeah. So he's basically had, this patient's got a right upper lobe. That's okay. Okay. What about this one? Is it a man or a woman?
Woman.
Okay, thank you. What's she got?
Left lower zone consolidation.
Because. Again. Got right middle lobe consolidation because obscuring of the right heart border. Can you see? You can't see it so well here. That's obscured.
Is there something on the left-hand side as well, just next to the heart? Or is that
No,
the breast?
it's the breast shadow. Okay. What's going on here really quickly? I think this is the last one. Because
Mediastinal displacement to the right and a big black lung field, so tension pneumothorax.
yeah. Should this patient should they have had no? Okay. What's happening here?
Incorrect placement.
Aspiration.
Aspiration unit.
Yeah, they've got an incorrect placement of their NG tube. This should never happen, basically. You probably get training on this once we do down the records, but I think this is it, isn't it? Yeah. Okay, I won't go over abdominal X-rays because we've completely run out of time and overboard, but it's the same sort of stuff. Okay. What I'll do is I'll put handouts for, and they're just basically A4 sheets of paper of how to interpret chest X-rays, just a checklist, abdominal X-ray, and then we'll try and put as many examples as we can from real patients without their details. And then you'll have to sort of blog to let us know if you want more or less or whatever else you want. Is that okay? Sorry, it was really, really quick. It was really
Great, thank you.
Do you guys have any questions about anything?